pratique. La préparation pulmonaire et les complications sera donnée par le docteur Mansour Dib, qui est un jeune médecin, American Board of Physical Medicine and Rehabilitation, très actif en publication et recherche, président du comité de médecine physique à l'IUB au Liban de 2009 à 2010. Donc un aspect très intéressant de l'adaptation, la préparation pulmonaire et les complications, préparation à l'artitude. Docteur Dib. Vous allez parler en anglais ou en français?
Do you mind if I speak in English?
No, not at all. We have a translation.
Okay, great. Thank you. Thank you for inviting me. I did my residency in the States with sports medicine, physical medicine, and rehabilitation. Joined AUB actually when I came back in 2007, but now I'm in the French system, so I'm back to Hôtel Dieu, back to being a francophone. Still, my medical side is a bit more English than French. I do love mountains. It's my passion, so it's probably why I was invited to give that talk by my colleagues. You'll see during my talk there'll be a lot of pictures of the mountains I've been to. Some of them I would like to go to, and I would comment on them if you don't mind, just to make things a bit lighter. This is called La Grande Coulée. This is in the Sannin Mountains. So, هيدي غرفة الفرنسوية ici. And then this is what we call the Grande Coulée. الشباب المنطقة بيسموها البحصة. The Bahsa. So the altitude here is about 2,550 meters. More and more people are traveling to high altitudes. Not only tourists, but also mountain rescuers, military operations. If you think about the American war in Afghanistan, I mean, those people were dropped at 4,000 meters right away, you know. Everest Base Camp is at 5,364 meters. It's one of the most common places visited on Earth at that altitude. And it's a place where a lot of research is being done for altitude medicine. Altitude-related illnesses. It's a group of group of syndrome, let's call them. They go from acute mountain sickness, AMS, then HAPE, high altitude pulmonary edema, HACE, high altitude cerebral edema. And there's some other minor ones such as high altitude retinopathy. They're all interrelated, and the main factor in them is that hypoxia of high altitude. It creates that chain of events, that physiological chain of events that creates them. AMS, acute mountain sickness, and cerebral edema are very related. Some people think that it's just like both ends of a big spectrum of the same physiological change happening. Pulmonary edema is also there and is very related to these two. I'll start talking about acute mountain sickness for a few slides. In French they call it le mal aigu des montagnes. South America it's called soroche. And it happens, basically the faster you go up, the more it happens. So if you are taken from an altitude of 0 meter to 3,000, to Urnet Sauda, which is 3,080 meters, right away you probably get some acute mountain sickness. If you go up gradually, then the incidence is less. The more you go up and the faster you go up, the more you get it. If you don't get it the first time, it does not mean that if you go back again that you won't get it. It's not predicted this way. Mount Elbrus, you might tell me that in Lebanon we don't have mountains that high. True, but mountaineers and sportsmen and tourists in Lebanon are traveling more and more abroad to mountains around us. And around us there are lots of peaks that are around 5,000. You know, Mount Ararat is one. Kilimanjaro, Mount Ararat is in Turkey, Armenia. Kilimanjaro is in the highest mountain in Africa. Mount Elbrus is about 5,600 meters. It's the highest mountain in Europe. So people are going there. Last year, a group of 10 mountaineers from Lebanon went up this mountain, Mount Elbrus in Georgia, 5,600 meters. What is the cause of acute mountain sickness? It typically happens at an altitude of around 2,500 meters. There's no predilection based on gender or fitness level. So people who are very fit, they can still get it. Actually, some people say that if you are fitter, you might get it even worse. It's more likely if it's a rapid ascent, if it's lack of acclimatization, and there's a heavy exercise at altitude. Individuals are not born the same when related to mountains. I mean, some people are very sensitive to mountain sickness, others not, and we don't know why. It's basically due to the hypobaric hypoxic of altitude, alteration of cerebral blood flow happens, and then there's also a tendency for fluid retention, and there's the role of the antidiuretic hormone on that. The exacerbating factors, like I said, sudden ascent, exertion soon after arrival, but also things that depress the ventilatory response. Alcohol at altitude, sedatives, especially if people cannot sleep well, they tend to take benzodiazepine. This will increase the mountain sickness, and narcotics. What does it look like? It's like a severe hangover. It's like if you drank too much alcohol and the next day you have the gueule de bois actually. There's headache, it's bifrontal headache, there's nausea, anorexia, lassitude, insomnia, decreased urination, and it happens about few hours after you reach the altitude. Sometimes there's something else going on and we mistake it and we say, oh, it's acute mountain sickness. And that can be dehydration, hypothermia, this whole list of things. Especially watch out for the carbon monoxide poisoning that can happen from the stoves that people are burning at that altitude to keep warm. It's Mount Kilimanjaro, it's about 5,900 meters. It's an easy mountain. So people think, okay, I'm going to reach the summit of that mountain very easily. The problem is, fit people, yes, can walk it, but then the altitude will hit them fast. And it's one of the most common places on earth to get acute mountain sickness and so on. And the guides there will tell you, the first thing the guides there will tell you, polle polle, is basically slowly, slowly, take it slowly, slowly. How do you prevent it? You prevent it by going up not more than 1,000 meters of dénivelé of altitude a day. You delay exertion if you can at the altitude. If you need medications, you take medication. The medication of choice is acetazolamide, Diamox. Some people say you take 125, other 250 milligram PO twice a day. Dexamethasone is another form of prophylaxis, 4 milligram PO TID or 4 times a day. It should be started before the ascent. To treat an acute mountain sickness, you don't need much. Basically, it resolves in 1 or 3 days, even if the mountaineer does not descend. If severe, you can take the acetazolamide to improve the acclimatization. Resting is the most important treatment. However, if you take the acetazolamide, know that it might have some side effects, such as paresthesias of the feet and fingers, and also a funny taste in the mouth with carbonated drinks, actually. There's a funny metallic taste in the mouth. The one thing not to do if you have acute mountain sickness, do not go up. Because then there can be HAPE or haze, and then there can be death. So rest, 24, 48 hours, and then go up. Our 2 highest mountains, Jabal al-Sheikh, 2,814 meters. That summit, the actual summit, is in Syrian territory. But actually all the slopes are Lebanese, yeah. Unfortunately, it's in Syrian territory. Ernest Sauda, 3,086. This is the circus of Al-Ariz, and then Ernest Sauda is beyond that. So these are the highest mountain in the Middle East. The closest mountain, the closest mountain to us is Mount Ararat. Pulmonary edema. It's the most common fatal complications at altitude. It kills either because people do not recognize it or mistreat it, or sometimes they cannot descend. If there's a big storm on the mountain and there's a patient with pulmonary edema, they won't come down and they'll die. It's a non-cardiogenic edema. It's related to the hypoxemia and the pulmonary hypertension that comes with it. It can occur even in fit and acclimatized mountaineers. So It doesn't mean that it cannot occur if somebody is fit and somebody did not get a HAPE before. Now, if somebody has a HAPE, a history of HAPE, it will be more, basically, he has more risk to get a HAPE again, so he is HAPE sensitive. Individual susceptibility is a risk factor, ascent rate, altitude reached, as we said, time spent at altitude, cold weather, if patient is breathing cold weather, exertion, upper respiratory infection, if the mountaineer is carrying a cold with him up the mountain. Maybe males are more affected than female, we don't know why. And pre-existing conditions that increase pulmonary blood flow, so left to right shunt, etc. I mean, some people are not diagnosed until they have HAPE on the mountain. Usually begin within 1 or 3 days after arrival at altitude. The lowest recorded altitude for HAPE is 2,100 meters. So, you know, we have plenty of mountains higher than that in Lebanon. Onset is usually at night. And do not think, if there's a dyspnea at rest, if the patient or the mountaineer is sitting and he is feeling short of breath, it's not normal. I mean, even, people tell you, even on Mount Everest, on the top, once you're rested, you should be fine and don't have dyspnea. You might feel fatigued, yes, you might have other symptoms, but you should not be dyspneic. This slide actually goes back to maybe answering the question that was asked earlier. What happens to people from high altitude if they go back down? You know, it's like there's something called re-entry pulmonary edema. For some reason, we don't know why. People with high altitude, living at high altitude for long term, they go down to low altitude and spend more than 10 days, then they return to high altitude, they can get what they call re-entry pulmonary edema. And it seems that it's fulminant, it's very severe. Thank you for preventing me from explaining this whole slide, because it was explained very well in the talk before me. The symptoms goes from cough in the beginning, dyspnea at rest, achy chest pain, and then it progresses to rales, frothy sputum, and hemoptysis. There's also a low-grade fever, 38 to 39. And you can imagine here, I mean, the main thing is to differentially diagnose HAPE from pneumonia. Now, the chest X-ray starts with a patchy infiltrate, typically on the right side. And if severe, there's a bilateral whiteout. This, as you see, there's typically on the right side. Typically, the clinical picture is better than what the X-ray looks like. And the patient is doing better than what his SpO2 are doing, you know, if he had pneumonia. Plus, the HAPE will respond very well to a descent or to oxygen therapy, basically. That will help in differential diagnosis. How do you treat it? You descend rapidly, at least 500 meters. High flow oxygen as much as you can. I mean, sometimes oxygen is not that available high on the mountains. People going on expeditions carry oxygen with them, but not that much. I mean, you don't have a wall-mounted oxygen supply. Have patient avoid exertion while going down. Well, that's not too easy. I mean, it's not very frequently that you're going to have 3 or 4 mountaineers to carry one patient going down, you know, a big mountain. But typically what we do is like we do not let him carry his backpack. We carry his backpack for him and go down the easiest possible. There is something called portable hyperbaric chambers, which are basically big bags that you inflate, and there's a pump in them, and they, you know, basically create a high pressure atmosphere around him. These can buy time. These are never treatment. These can buy time. We put the patient in them and we pump them, and these can buy time until the climatic conditions are better, so the patient can descend, or until maybe oxygen comes in, or there can be an evacuation. Okay? Medical treatment. If you can descend and you give oxygen, that's what you do first. However, sometimes you can use medications. For example, nifedipine is the most studied, and you know, works as a vasodilator of the pulmonary artery. 30 milligram of extended release Q12 hours. However, watch for hypotension. because these patients are typically dehydrated from the long ascent and from the effort on the mountain, so watch for the hypotension. Viagra and Cialis, basically, these phosphodiesterase inhibitors, have been studied extensively lately about the possible benefits for the treatment of pulmonary edema. And there is less risk of hypotension. I'll go over in a few slides about the possible benefits of these medicines. Dexamethasone for HAPE might work. It's better for HACE, but basically if you have it, you will give it to somebody who is gasping for breath. Salmeterol and other beta blockers have been studied, and there is a possible role for them. I mean, the studies on everything I said, they're rare compared to other part of the medical literature. They're rare because doing them is hard. I mean, studying mountaineers at such high altitude is hard, and you need to have the technical support, etc. That's why the Everest Base Camp is one of the most one of the better places to do these studies, just because there is so much supplies there. How do you prevent HAPE? Gradual ascent, again. Medications if gradual ascent is not possible, for example, doing military operations in high areas, or mountain rescuers who have to go up very high, very quickly to rescue mountaineers up there. These people, you start them on medication to prevent HAPE, and you can start them either on calcium channel blockers, dexamethasone, salmeterol, or PDA5 inhibitors, which are basically Viagra and co. As we all know, PDE5 inhibitors increases the nitric oxide and cause vasodilation in selective vessels. Some of these vessels are the pulmonary arteries, which decreases the pulmonary hypertension, which basically helps the pulmonary edema. The doses studied were for Viagra 50 milligram Q 8 hours, for Cialis, which has a longer half-life, 10 milligram Q 12 hours. They work for the prevention of HAPE, but there was a study that basically was comparing Cialis versus dexamethasone for the prevention of pulmonary edema. And they found a very interesting result, which is patients who were giving Cialis had more acute mountain sickness syndrome. And that makes sense because, with the vasodilation that comes with these drugs, you have an increase in the intracerebral pressure and then more acute mountain syndrome. So it's not indicated for the prevention of HAPE across the, everybody who's going up the mountain. It's more indicated to if somebody had a story of pulmonary edema before, wants to go back to the mountain, wants to climb another mountain the next year, you might think of giving him these drugs. Treatment of HAPE, it makes sense. It was never really studied in the randomized controlled trial for pulmonary edema, but it makes sense to give him Viagra or Cialis. Now the next interesting finding is that these medications seem to improve athletic performance in high altitude, in hypoxic environment. And that was published in the Journal of Applied Physiology in June of 2006, when they compared placebo to patient given sildenafil, which is Viagra basically, breathing hypobaric hypoxic air, and it seems that patient who had sildenafil had about 45% even improvement in the athletic abilities over the other ones. Few slides about cerebral edema, if I have time. Yes, I have time. If somebody starts acting funny and weird at really high altitude, out of character, you probably have cerebral edema unless proven otherwise. And MRIs done on patients who had cerebral edema have shown that there is an edema of the white matter. It is less common than HAPE, that's why it's less fatal. It's possibly the same thing as AMS, but it's a very severe AMS, comes from the increased blood flow in the brain. It can be fatal or even result in stroke-like syndrome that are permanent, and the onset is gradual, few days after arrival at the maximum altitude. Severe headache, confusion, agitation, hallucinations. Typically ataxia is the diagnostic thing because you have somebody with headache, and he's been having headache for 2 or 3 days, and you think it's a mal aigu des montagnes, and then that headache is increased, and then you're not sure if it is just like turning into a cerebral edema or not. Have him do the heel to toe, walking on a straight line, and see. Treatment, the only treatment is to take him down. I mean, you have to take him down. You can try oxygen, dexamethasone, IV in this case, or you can even try to diurese him to prevent, basically to get rid of all this extra cerebral fluid, that you have to take him down, otherwise he'll die. Mount Ararat is another very frequent mountain that people are going up to these days, very close to us, very accessible. These are a few slides of retinal hemorrhage of high altitude. We don't know why they happen, probably because of vasodilation, again, as it goes with the vasodilation of the intracerebral arteries. They don't affect vision unless they are macular, basically. Incidence is 20 to 40% above 4,000 meters. Does not affect vision, like I said. Diabetics are at high risk, and usually no treatment is necessary. Miscellaneous altitude-related problems. There seems to be a tendency to more venous thrombosis and pulmonary emboli because of high number of red blood cells. And there's an immune suppression. People who cut themselves at high altitude, they know that they'll take longer time to heal, and there's a high risk of infection just because the white blood cells do not act as well because of the hypoxia. And thank you.
Thank you, Dr. Dib. It was highly interesting. I'm sure there are a lot of questions. And may I congratulate you for the beautiful design of your slides. It's really
thank you.
Aesthetic. Any question? So apparently we can survive HAPE. Yeah. And what are the key elements or measures that really are important to survive HAPE?
Recognizing it, actually. Just knowing that this is HAPE. It's not normal, dyspnea of effort, like if your friend on the mountain is having shortness of breath and more problems while sitting, that's probably HAPE. And it comes at night because people, when they lie down, that's what happens to them. When they lie down, the fluids come up to the heart. Mm-hmm. And if I might share my own experience, it happened to me once in the States, in Colorado. We flew right away from the very low altitude to this mountain resort. And at night, 2 days after getting to the hotel, which was about 4,000 meters, like I was sitting in bed and I was fine. As soon as I laid down, I started feeling that the covers were too heavy, like I could not breathe very well. And I'm like, I'm getting HAPE. Mm-hmm. So I sat back up and things went better. But this is how easy it can be, how quickly it can happen. And then the next day, I didn't descend. I was ready to descend, but this is how easy it can happen. And then the next day it's gone for some reason.
So starting the point where you recognize HAPE, you need to be fast in descending.
Yeah, fast in descending. Oxygen, if you have it,
yes.
Recognize, and descend it. If you have dexamethasone, decadrone,
that's what helps.
Give it. If you have, one of those Viagra or Cialis, give it, and then take the patient down. Sometimes descending, you might think it's very easy because you're on top of the mountain, you just go straight. Sometimes you have a pass. Sometimes you are 5,000 meters, but to descend to lower altitude where you can camp or where you can have medical help, you have to go back up to 6,000 meters and then go back down. So this is really, really complicated sometimes. Sometimes even like helicopter evacuation is not available, Mm-hmm. And with this whole race to summit mountains and the highest mountains and Everest, it's becoming catastrophic. People with very, very, very poor mountaineer experience are paying huge amount of money to go up these really high mountains. And the expedition guides, they want to take the money and they take you up.
True.
There were lines this year on Mount Everest. There were like 200 people waiting in line at 8,000 meters. having paid $60,000 just to go up that mountain. So.
Any other question? Yes.
What's the criteria between safe part of the symptoms and to go to HAPE or the other?
Right. I think it's the desaturate. I mean, with
when we think about it safe, we can do rehabilitation or no?
Right.
Which the criteria?
I think it's like if things are not improving while staying at the same altitude, if things are not improving, if the mountaineer is getting even more like dizziness or even more like neurological symptoms, he's moving into haze, you know. In terms of like the pulmonary symptoms, you can have him rest, you can give him the medications and see what's happening, you know. Some people have more and more have like the portable oximeter and see what his oxygen saturation is. If it's desaturating, you go down, you know, basically. I mean, there's always that pressure that people don't want to come down the mountain. Everybody has taken like so many vacations and put so much money in training, and then you can tell him that you have to go down the mountain because, you know, you're short of breath, and there's this huge dilemma that can happen at 6,000 meters. So a lot of people have died because of it. Yes, you know.
That's a question. How many time we have to wait?
I think dyspnea at rest start thinking, you know, when the patient, when the athlete is dyspneic at rest, even sitting, start thinking that you have to evacuate him, basically.
Last question. I clearly understood from your presentation that previous history of HAPE is not a contraindication to go up again?
No, but it's a indication to really be attentive and pay attention.
And to be prepared for that.
And to be prepared, yes.
Okay, yes.
Dr. Dib, clearly gas exchange is challenged by exercise and altitude.
Right.
So people that go up those mountains, what do you put them through, testing-wise, to see whether they are fit for such altitudes or not?
I think the best, ideally, I would like to have them, to see them or like to hear from them how they do at high altitude. Because I mean, there's not much we can do on low altitude to basically reenact that environment. However, I mean, you're going to see the VO2 max, you want to see how much fitness, I mean, the resting heart rate, like a stress test. This is all you can do at low altitude. Otherwise, you want to see them how they perform at high altitude, and typically it comes from their training, and you know that, you know, basically if they've done their training at high altitude. If they don't have any previous mountain experience, you ask them to go up basically gradually and see what happens.
Okay, so last question. Do you have, yes, please quickly.
Thank you for the presentation.
Sure.
And one last question. Maxim Shaya said that he trained a lot before going to Mount Everest. What type of training did he receive?
Well, training at high altitude.
The gradual.
Actually, I used to see Maxim Shaya running between Jonction, Bifareya, Werde, which is an altitude of 2,200 meters typically. He used to be running there. I mean, the whole thing is to increase your erythropoietin, increase your red blood cells, and be in that level. And then go up gradually. That's the main thing. Go up gradually.
Excellent. Very interesting. So, thank you very much, Dr. Dib.